Thank you. Sorry about that. Afternoon, everybody. I've got a case presentation of a complicated patient that has been in hospital for a while now, which we thought was a quite interesting case. We present a young female patient who's HIV positive, on treatment with an undetectable viral load and a CD4 count of 138. She had a background of about 2 years, which she describes episodes of on and off watery diarrhea, but over the preceding week had gotten severe. She was admitted extremely ill in hypovolemic shock, had to be taken to ICU. This was an abdominal X-ray, which showed multiple air fluid levels. CT scan was performed, and the radiologist was concerned that she might have had an obstruction. So the surgeons took her for explorative laparotomy. That was, however, normal. She developed in ICU acute kidney injury for which she required dialysis. Stool samples that were taken on the day of admission was negative for routine organisms. However, it was positive for C. diff, GDH, the PCR, as well as the toxin was positive. She was treated with vancomycin as well as metronidazole. She improved, was able to be discharged from ICU into the G floor around 1 week after starting treatment for Clostridium difficile. She developed worsening diarrhea. She had minimal abdominal pain at this stage. Repeat stool cultures were performed, and it showed Cystoisospora belli, as can be seen in that picture. She was subsequently started on cotrimoxazole. At this stage, due to a worsening diarrhea, we also performed a colonoscopy, which was consistent with pseudomembranous colitis. After more than a month in hospital, she was discharged on antiretroviral therapy as well as cotrimoxazole 2 tabs. Shortly thereafter, however, she represented again with severe watery diarrhea. Stool samples this time was GDH positive, PCR positive for C. diff, but the toxin was negative. The modified acid sphos smear again showed the Cystoisospora. She was treated with high-dose Bactrim again for 3 weeks. The team taking care of her also elected to treat her with vancomycin. This time they used a pulsed and tapered regimen. After about 2 weeks, the diarrhea resolved. She was kept for a further week in hospital to just monitor her, and then she was discharged. About 3 days after discharge, she came back. She said that she had missed a single day of her cotrimoxazole. Again, severe diarrhea, severely ill patient. So just when looking at a patient that is immunocompromised of HIV and has chronic diarrhea, described this like more than a month. In our setting, cryptoisosporiasis is probably the most common, along with Cystoisospora belli. Obviously, TB is always a concern. And then with lower CD4 counts, we can think of things like MAC, CMV, and lymphoma. And then finally, HIV or AIDS enteropathy will be a diagnosis of exclusion. This is just the workup that you will do. You will send the stool for routine organisms, looking for ovine parasites 3 times, as well as C. diff testing. If you don't find anything and you've got a suspicion of colitis, patients may present with pain or bloody diarrhea, then you could proceed with a colonoscopy biopsy. If they don't have any evidence of colitis, upper duodenoscopy and duodenal biopsy can be performed. If you've excluded everything, hasn't found a cause, then you might think of HIV-associated enteropathy. So just with our patient, interpretation of the C. diff testing was quite a challenge. These are the types of tests that we use in hospital. We use GDH, nucleic acid amplification, which is PCR, as well as looking for the toxins. An algorithmic approach is suggested. So if the GD is, and we use option 1 in our hospital, GDH is negative toxin negative, patient doesn't have C. diff, GDH positive toxin positive, patient does have C. diff, and GDH positive toxin negative, which was the case in our patient on a readmission. You have to do PCR testing. In this case, a PCR was positive, but there was no toxin detected. If the PCR is negative, then the patient doesn't have C. diff. So, questioning this patient, should she have received retreatment for C. difficile during a readmission? This was an American study performed at the Washington University, and they looked at 150 patients that was admitted with diarrhea. The inclusion criteria was basically any hospitalized patient with unformed stool, and they sent away for C. difficile testing. They looked at 9 different methods of testing, including toxigenic PCR testing as well as toxin assay testing. They compared this to toxigenic culture positive patients and then an eventual clinical diagnosis of C. diff infection by the treating clinicians. And what they found was that the absence of toxin detection had a fairly high negative predictive value, whilst the positive PCR for a toxigenic strain of C. difficile only had a positive predictive value of 60%. Sorry, I said, you know, the toxin, if toxin is negative, a high negative predictive value of 96%. This is just the detection methods of Cystoisospora belli. So on top, if you've got heavy colonization or infection, you can sometimes see it on a wet mount. We use modified acid-fast staining, which improves the detection rate. You can also use fluorescence microscopy. If you suspect it in your patient and stool samples are negative, you can proceed with an upper endoscopy and duodenal biopsy. Agents that are active against Cystoisosporiasis, cotramoxazole, cipro, pyrimethamine, and nitazoxanide. So what we wanted to talk about was this paper that was done here a few years ago in Western Cape by Dr. Boyles and the infectious disease team here. They describe 8 cases that have relapsing cystoisosporiasis in HIV-infected adults, despite reconstitution of their CD4 count and viral loads that were undetectable. Initial low CD4 counts might have been necessary for an infection to be established, but despite T-cell reconstitution, they failed to clear the infection. This might be related to loss of antigen-specific immune response to Cystoisospora in the gut. Evidence for this is that these patients didn't have other opportunistic infections, only developed the Cystoisospora. We also know that HIV treatment can only lead to partial restoration of gastrointestinal CD4 cells, and therefore gut immunity may not fully recover. Drug resistance was also questioned in the paper, but all 8 patients recovered fairly soon during hospitalization on high-dose Bactrim or IV therapy, so it was thought to be unlikely. In other patients, Cystoisospora has also been found in intestinal lymphoid tissues, as well as the biliary system, and including gallbladder in some patients. And this may represent sites of chronic infection. So back to our patient, unfortunately, she's still currently admitted on the G floor. In light of the C. difficile toxin that was negative and the absence of symptoms of colitis, we elected not to treat her for C. diff. She's currently on IV cotramoxazole therapy. So just some key points. HIV with a chronic diarrhea may require an extensive workup, including endoscopy. We use an algorithmic approach for C. difficile diagnosis. Identifying parasitic causes will require special staining methods, which should be requested by the lab. And patients with cystoisosporiasis will require extended prophylaxis with cotramoxazole, and often in some patients, they might never clear it despite the high dose of prophylactic therapy. Thank you.
Great, Wilhelm. Thank you very much. A really nice presentation, short and sweet, but really to the point, and that's great. Can you stop sharing your screen and just put on your video monitor? be interested in people's comments. As Wilhelm said, I think these two issues of how you deal with a patient who's got recurrent diarrhea, coming in with the C. diff toxin negative but PCR positive, that was one issue. The medical team decided on initial readmission to treat, and we decided on his second readmission then to not treat. And then this category of patients who clearly, despite virological suppression of HIV and an improvement in CD4 counts, actually continue to come back with recurrent cystoisospora. Maybe the need in these patients to treat rapidly with intravenous therapy, antibiotics rather than just oral. So while you're thinking of your comments and your questions, I'm going to ask our microbiology colleagues to take us through when a patient comes to you, when samples come down to you with chronic diarrhea and HIV on there, what are the tests that, what would your algorithm be in terms of looking for protozoan parasites? And maybe I can ask, I don't know who's here, either Amanda or Hafsa, please, or whoever else is there. No, it's just Hafsa and Amanda. So one of you, please, if you could take that question, thanks. And if in answering you could put your video on, that'd be great. Okay, I'm going to ask Hafsa. Hafsa, can you pop your video on and explain to us what you do?
Hi, can you hear me?
Can, thank you.
If
Can't
it's
see you
stated
yet.
on, oh, sorry. If it's stated on the form that it's chronic diarrhea or HIV, we look for parasites routinely.
That's great, but what are the tests that you would do?
Modified acid fast staining, and it's an immunofluorescence stain, and we see it quite easily if it's there.
Okay, so if that's negative, at what stage would you look for microsporidiosis?
No, we don't look for microsporidiosis. I think for that you need to have electron microscopy. So we don't do it routinely in our laboratory.
Okay, and do you do auramine phenol stains at all?
Let me just think.
It's another way of seeing cystoisosporiasis.
Sure. Maybe I can defer to one of my other colleagues. I've been out of the lab now for a bit and I can't remember.
Okay. So Amanda says, yes, we do auramines. Great. Okay. So Jan-Lut, how much of this do you see recurrent chronic Isospora, and do you agree with the way that this was managed in terms of not treating for the C. diff infection when the toxin's negative, or what are your thoughts?
Hi, Prof. Thank you.
Hi.
So I actually don't see that many Isospora belli recurrent infections in where I work at the moment. So I haven't dealt with this problem for quite a while. I don't know why that is necessarily. If it might be just in part, more antiretroviral cover. I'm not sure. As to the clinical problem that was stated, that the dual infection with the PCR positive for C. diff as well as stain positive for Isospora belli. I don't really know whether the fact that the toxin was negative on the second sample might necessarily push me towards not treating, as there are, I suppose, a few reasons why the toxin might be falsely negative, and the Australian microbiologist can shed some light on that. So I would probably still have treated for both, since I'm not actually quite sure how to tease out exactly which one of the two or both are the problem, at present, and I suppose it is a big problem because you don't want to give broad spectrum antibiotics for the C. diff but you also need to address the Isospora belli. So I was thinking the whole time when they spoke what I would do, and I was actually hoping you wouldn't ask me this question because I don't really know.
Well, that's good, because I mean it shows that even the most experienced ID specialists, we're not quite sure what to do about this. So maybe we could go to Professor Wasserman, who sits in the Tom Boyle's chair of diagnostic testing, and ask you, Sean, about your interpretation of that from that American study of the value of a negative toxin test. I mean, I'm sure that if need be, Wilhelm can put up that slide again, but it had a negative predictive value of around 96% and a positive predictive value of, if it was positive, of I think 58%, if I remember right. Sean, what do you think?
Yeah, I mean, it would be helpful to have a look at that slide again. I mean, just to distinguish and understand what we mean by by this term, positive and negative predictive values. And so it's not an inherent characteristic of the test, like sensitivity and specificity. That's got to do with the pre-test probability or the background prevalence, right? So the positive predictive value will of a positive test will go up when there's a higher pre-test probability and is related indirectly to the sensitivity, and the opposite for negative predictive value. So these values depend on where you do the study, right? And so that's the first thing to say, and I don't remember the numbers, but as Jan Lewis said, I mean, I think microbiologists are the best positioned to speak about the internal performance characteristics of the tests, especially the tests that we use here, because I know that there are a lot of manufacturers of the GDH and of the toxin tests, and they all will perform differently, and they'll perform differently under different conditions. And so, I think we should get input there. My understanding is that the sensitivity of the toxin test is relatively poor, and that's why we have this algorithm. We screen with a highly sensitive test, GDH, which lacks specificity, and then confirm it with a less sensitive test, which has much better specificity, the toxin. But that's the limitation, right? And so you can definitely have C. diff infection with a negative toxin test. And that's why it's really difficult to diagnose recurrent disease, because the GDH can remain positive and probably will remain positive. I don't know for how long. And the molecular test will remain positive, both if there's persistent colonization or recolonization. And I think it's impossible actually using these tests to tell whether there's recurrent disease if they're negative, if the toxin test is negative. And in my practice and my thinking, you have to just use clinical judgment, just like you did.
So Professor Boyles would be weeping with joy at your answer, I'm sure, and thank you for that. And I'm going to ask Amanda perhaps to address this, but before that, Sipo's had his hand up. So Sipo, what are your thoughts?
Yeah, no, I was just going to say, Mark, that the unusual thing about this case is that in our experience, the patients with this chronic isospora have often only just had that infection and nothing else. So dual infection is quite unusual. And I think if you had seen this patient in the beginning, you would have predicted that they're going to come back with diarrhea. And you would then probably have to have a management strategy going forward, because, the first admission was with C. diff and with isospora. And, we know that these patients with isospora often come back with repeated episodes of diarrhea. And I think the difficulty would have been the interpretation of the C. diff results on a second or third readmission. And I think that's just something unusual in this particular case. So I think the clinical thinking or judgment on whether to treat for diarrhea probably played in that kind of experience, knowing that the most likely cause of reoccurrence would be the isospora infection rather than the C. diff. But again, that's a clinical judgment at the bedside. And I think the point of really understanding the tests in your laboratory is key in terms of maybe helping you sway you in one particular direction. Thanks.
Thanks very much. I mean, obviously it's sample to sample, but the toxin was positive initially in the first presentation, and of course that did require treatment, and he had pseudomembranous colitis on colonoscopy. So I think we're clear that there definitely was C. diff, active C. diff toxin being made. But as you say, it's a clinical judgment. So to round off, Amanda, can we ask you just to give your interpretation of the negative toxin in this case and what you would have suggested?
Thanks, Prof. Just to reiterate that Sean is correct, and that's why we have this two-step approach, in the sense that the GDH in itself has a higher sensitivity, whereas the toxin is got more specificity. The combination of the two together, combination of the two together then improves the testing for it. But because of that limitation, that's why we reflex to molecular testing in itself as a confirmatory for toxin.
Okay, so the jury is out, I think, be fair to say. I don't see any other hands up, so I'm guessing that, that people are happy with the discussion. And we can thank Wilhelm for a lovely presentation and an interesting, reminder of this issue of why. I mean, we haven't got into this discussion again of why this might be happening. We did have plans at one stage to I think Dave Stead was going to have a look at the possibility of cotrimoxazole resistance in Isospora, but I think there's quite a lot of difficulty in actually doing that. But we do see in other Cryptococcus and other this issue of antigen-specific immune defects to particular antigens, and maybe this is again something that has occurs with Cystoisospora. So something to look out for in recurrent diarrhea